this presentation. So we've just begun, and I will turn the floor over to all of you. Well, we're a minute early, but I think the gods will forgive us.
How many are we looking at so far, Lynette?
49 participants.
Whoa,
49, yeah.
We're going to want a breakout room towards the end unless I don't get
Sure.
my slides in time.
Yeah, no problem. Just let me know. I'll be here.
Okay, thank you. Okay.
Welcome, and a lot of people, how are we going to do this?
They've left in disgust.
Just a reminder, as people are coming into the room, for some reason you are coming in unmuted. I'm sure that's just a box on the settings to change, but that hasn't been changed. So please be mindful of the mute button, bottom left of your screen typically. Thanks. So let me introduce this presentation.
I'm Catherine Faith.
My name is Lynn Westerford, and I am a project manager at SHARE. I'm very pleased to be here. My first conference. Thank you for your patience. And welcome to the 2 p.m. session of the Bridging Research and Practice Conference. All of these presentations are being recorded and will be made available at a later time. The slides will also be made available to those of you who would like to check them. If you have any questions or technical problems.
I'm hearing a lot of background noise.
Okay.
And Winnie, I think it might
part
be
of that is
because Catherine is in your room.
Yeah, I have a couple other people in my room who are reading the same script as I am. So
Do we want to do, if you mute yourself, we can read the script on our end, like Libby or I could read that script.
If you could just introduce, okay, they're finished. So just briefly, if you have any technical questions or other questions, you can direct message me in the chat. And you can raise your hand if you have a question. You can also put a question in the chat if you have a comment for the presentation. And we're also going to be putting an evaluation in the chat that we'd love for you to participate in. And finally, if you wouldn't mind, as some of you are doing it already, thank you, adding your name, your organization, and your email to the chat. That way we can document attendance and also have contact information for following up with that evaluation if it falls through the cracks. So today, at 2 o'clock, we are now going to hear about what is recovery. And Dr. Lee, I keep mispronounced, I'm so sorry, Kaskutas is going to talk about her NIH-funded What is Recovery study. And I'm going to turn it over without any further ado to our Dr. Kaskutas. Thank you very much.
You're welcome. And I did a bad thing and lost the way I can turn on the screen. What did I do? Oh my gosh. I'm going to go back in and rejoin, I think.
Hit minimize. You can click on the Zoom logo at the bottom of the screen. Sometimes that works. I think she's about to rejoin. Thank you for your patience. Thank you for putting your information in the chat. We're very glad that you're all here. Special shout out to all the PWI and EPOC grantees.
There I am.
There she is.
There I am.
Share Do I need to make you a co-host again? Yes. There you go. Okay, to you, Doctor.
Thanks. Oh, please work. Please work. Where's my talk? There you are. Thank you for your patience. The minus sign slideshow, there we go. Yay! Thank you for coming to this session. I'm so excited. I was telling Jason before we started that if ever there was an audience that my entire career was guided towards wanting to talk in front of, it is the people today. So thank you for this opportunity. I'm going to be talking about the biggest study I ever did, and possibly that I've ever heard of in our field, called the What is Recovery Study. And in it, I'm going to talk really fast because I have 48 slides and I want to do a breakout room. So I'm going to talk about the rationale for the project, a bit about the methodology. So there'll be some science there, but it won't be too agonizingly difficult, I promise. Talk about the study results in terms of what the definitions were that we came up with the help of, almost 12,000 people, how the concepts are organized into groupings, like maybe spirituality, but we'll see what we find, and how the definitions of recovery are grouped by people based on their pathway to recovery, or whether they're on medication-assisted recovery, blah, blah, blah. Talk about the significance and how you can use this in your clinical practice. And that's what we'll be talking about during the breakout rooms. Under methodology, you'll see I've said that recovering people are involved in every step of the study execution. And when I asked my partner, who's the co-host of this, Thomasina Borkman, what was something I really needed to not forget to say, she said, don't forget to say that. We had recovering people on the study every step of the way. And the study would have been a piece of garbage had we not done that. It would have been a disaster, because others have tried to study how people define recovery without using recovering people to talk about it and their definitions. Well, I'm going to talk to you about what some of those definitions are and see what you think. In the medical and scientific field from which I come, I'm in public health doctor. You hear about recovery equated with remission from a DSM-4 diagnosis, from remission from high ASI problem severity, or remission from no longer heavy drinking or drug use. Or you'll see articles and trials of different treatment solutions, and their important outcome is recovery, but they define it as abstinence, and maybe just abstinence for 1 month. And they see it as recovery being something that's getting rid of negative things. And based on my observing thousands of AA meetings and hundreds of treatment groups, I don't think people in recovery see it as getting rid of negatives. They see it as something positive. And I think part of the problem with all this huge amount of scientific research and money thrown towards the addiction field, and we still have this stupid stigma idea. I mean, it's everywhere. I don't want my daughter to marry a recovering alcoholic, for heaven's sakes, is because it's not seen as positive. And I know it is a positive. And so we're going to see what kind of positives that might be. In 2006, I was fortunate enough to be invited to the Betty Ford Institute's expert panel, so-called expert panel of addiction researchers, mind you, to come up with a definition of recovery. And this is what we came up with. It's a voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship. Well, what do you think about that? Just tell the chat. You like that? Some of it seems pretty good. Let's see how they define those things. It's abstinence. Sobriety is abstinence from alcohol and other non-prescribed drugs. Personal health is improved quality of life, and suggests quality. And the panel suggested that the way to measure quality of life was using the World Health Organization quality of life scale that had all these different domains like physical health, psychological health, independence, and spirituality. And the idea of citizenship, they defined as living with regard to those around you. And all of these things sound pretty good, don't they? In terms of, in general terms, that might be how recovery should be defined. But when you look at the WHO items that define social function, environment, etc., you get stuff like this. To what degree does the quality of your home meet your needs? How easily do you get tired? To what extent do you have opportunities for acquiring the info that you feel you need? Here's a good one though. How much do you enjoy life? I like that. How much of a connection do you have, etc.? How important is it to be free of negative feelings? Some are positives, but are those what you would have written down had I asked you to define recovery? How does the quality of your home meet your needs? Maybe for some people, yes, I don't know. So I wanted to try this out. I had been on this panel. I had told them I didn't think these World Health Organizations were going to do it. And they said, well, why don't you just go write a grant and see if you're right? So that's what I did. I got funded, and I told the grant reviewers that I wanted to develop a recovery definition that reflected the heterogeneity, the very many ways of recovery that are out there. I wanted the definition not to come from expert panels at institutions, but from people actually in recovery. And to do that, we had to go far and deep to find the hidden population of people in recovery. There's not like a website or a mailing list of everyone in recovery in the world. The study was developed in 2 phases, and I'm going to spend a lot of time talking about item development because it was more of a challenge than I would have thought. We wanted to get 12,000 people in the end who were in recovery to participate. To be in the study, you had to be 18 or older, and we didn't ask about your diagnosis. We didn't give you a DSM-4 remission diagnosis, none of that stuff with this. You said, I'm in recovery, or I'm recovered, or I used to have a problem but don't now, or I'm in medication-assisted recovery. That was it for eligibility, which made the grant reviewers kind of hate it. But eventually I got funded with this as the criteria. It took us 19 stupid months and 4 steps to come up with a batch of items. Thomasina and I worked like dogs, as did the whole team. And I'm going to drag you through some mud here. We started out thinking, okay, we're going to ask our cronies in recovery and our colleagues who study recovery, some of whom are in recovery, to write sentences about how they defined it. And about a month later, nobody had sent me a single sentence, even though these are people I nag the heck out of. And it just came to, it was hard to define it beyond broad terms like abstinent and healthy. So we talked to them and tried to write sentences based on what they said. Then we went to these World Health Organization items and tried to turn those into questions that made sense for recovery. We read all the articles that had the word recovery in it and wrote items using their definitions of recovery. We looked at the steps and tried to make definitions out of some of those. We looked at the promises and made items of those. And this is phase 1 of phase 1. We showed those items to people, edited, showed them again. We didn't stop adding items until no ideas that we hadn't heard of surfaced. This is what we ended up with. And I know you can read, so I'm not going to read everything from now on. I'll just say that there were some things that we excluded that experts wanted. One was they insisted that we added an item that said recovery is not lying to my family about where I'm going. Or they wanted us to use a 1 to 7 response category as an item definitely belonged or not. And I argued that there's a lot of flexibility in recovery. People might not have one thing be in their definition, but it might be next to their best friend. That might be part of their definition. That doesn't mean they would throw it out as a definition. So man, there were battlegrounds all over the place. This is what we came up with as our response categories instead of the strongly agree, strongly disagree. Definitely belongs in your def, somewhat belongs, does not belong in mine, but may belong in others. Doesn't really belong in any definition. Say this for things you really thought didn't belong.
Lee, can I
Yeah, do it.
interject that?
Yeah.
The one that is highlighted does not belong in your definition of recovery, but may belong in other people's definition of recovery is so unusual because it's just never done in survey research. This is so unusual, and it really shows that people in recovery think of recovery in community terms, not just by themselves. Okay, thanks.
Thank you. And I love that you said that. And please don't hesitate in the future. So we ended up with 167 items after all this stuff. And we gave those items to several hundred people. And we wanted to get diversity in terms of pathways and treated or not, ethnicity, et cetera. And then Thomasina led a group that talked to 54 of those people after looking at their answers, because they didn't answer questions or they were inconsistent or they wrote things in the comment section that we wanted to explore, right, Thomasina? And you talked to them for hours, and we made sure to ask about every item from people from every pathway, different times of recovery, different kinds of recovery, abstinence status, and drug of choice. We learned that I was right, yay, that the World Health Organization quality of life items weren't what recovery was to people in recovery. They just reflected being a human being. Another thing we learned that Thomasina could have told me from the start, had I listened to her more carefully, was not to set the bar too high. Don't look for perfection, progress, right? Not perfection. And we included items that some people we knew would not like, but that really would vibe in with your atheist, or that would be good for people that are not in 12-step recovery, because we wanted to have it be a broad definition that reflected the way people in recovery define it. We ended up with 47 items. Then we went on to phase 2. Yes? Unmute. Leave yourself unmuted.
Okay, we also identified words that people didn't know, and surprisingly, we couldn't use the word abstinence because a number of people didn't know what it meant. So we fashioned the terminology to fit so that everyone understood what we were talking about.
Thank you. Okay. We then tried to get 12,000 people in recovery. And we went to recovery organizations, treatment organizations, alumni organizations, the Christian Recovery Group, what is it called? Celebrate Recovery, minority focused, medication assisted. We got feds to partner with us. All of the self-help groups partnered with us. We went with, what is that place that's got the online meetings? I forgot their name. Doesn't matter.
Right.
We had informal partners. Addiction magazines helped us by putting ads in their paper, banners on websites, because 12,000 is a quite big number. And they helped by posting it, and I already said all this. Yeah, that's okay. We don't need to skip that. We went to Craigslist, electronic media. It took 3.5 months of constant effort, being on TV, being on the radio, going to conferences. We had a thermometer on our website. It was an online survey that showed how close we were to the 12,000. And we finally gave up at 9,541. And this is what we got in terms of gender, ethnicity, not on this one, genders here, age. Let's see. 75% said they were in recovery, which means, listen up, you may not like it, but 25% of the people didn't use that term, but yet they were in our study and wanted to be in our study. Four 4% were in natural recovery. That's a very hard group to find. And it's a small percentage, but when you have almost 10,000 people, you get enough people to do statistical analysis that don't exclude them. Different lengths of sobriety, different amounts of 12-step exposure. 15% had only gone to 12-step. 84% were totally abstinent. That meant 16% were not. And yet they were in recovery or recovered or used to have a problem. We did our best to reach ethnicity groups that are not usually well represented. Again, we got good numbers, if not large percentages, of minority groups, even Native Americans. Thank you. Beliefs about recovery in terms of substance use. Let's get into this one. Only 87% felt it meant abstinence, 4% no use of substance of choice, 9% moderate use. We got a sample similar to other studies. And our treated respondents in the sample were similar to studies of treatment samples. We used an analysis called factor analysis with these 47 items to figure out whether there were groupings of things that kind of hung together in terms of how people answered them. And they did. It grouped into 4 factors. And Thomasina and I and our other 8 colleagues sat around the conference room table. I remember it was over the Christmas holidays even, trying to figure out these. The computer would just say there's 4 factors. It didn't know what those factors meant, right? So we had to look at the items and talk about it to see what was the essence of those items. There were 35 items out of the 47 that got retained by the computer. And they were in an abstinence factor, essentials, enriched, and spirituality factor. And I'll show you items from each one, so don't worry. 12 items didn't fit into any factor. The computer said, these do not belong. But Lee and Thomasina and the other 8 people on the study said, no, there were 4 uncommon items that represented unusual definitions from people who weren't necessarily mainstream recovery kind of people. And we got rid of the other 8. And here are the items. And would that we were in a room so that we could go around and take turns reading them, because you're gonna get tired of having me read. So why don't you just take a minute and just look at the abstinence and recovery items that I've just circled. Everybody see that? You see that some people were okay with using non-prescribed drugs. Essentials of recovery, being honest with themselves. My favorite item of all, being able to enjoy life without using and drinking. Handling negative feelings without using drugs or drinking like I used to. This is a good example of what Thomasina and I were talking about with the use of language and of no perfections. It's not enjoying life, period. I'm happy all the time. Life is great. It's without using, handling negative feelings without using like I used to, changing the way I think through things, not replacing one bad thing with another, taking care of my mental health, not completely, not perfectly, not meditating every day all the time, more than I did before. Where'd my cursor go to? You can see that, right? The cursor? Good. A realistic appraisal of my abilities and my limitations. And that's something I have to work on every morning, along with my gratitudes list. That is a tough one. And that gets at not being God, by the way. Being able to deal with situations that used to stump me. Freedom from feeling sick because of using. Striving to be consistent with my beliefs and values in activities that take up the major part of my time. Not using people in the relationships. Getting along with people better than I did before. Again, this is progress, not perfection. Okay, that's the essentials. Now we have enriched. This is Thomasina's favorite item, a process of growth and development. And I bet her money that that wouldn't make the cut, but it did. And I owe her, I don't know that I've ever paid you, have I, Thomasina? And now you're working for free again. Taking responsibility for the things I can change, reacting to life's ups and downs in a more balanced way, living a life that contributes to society, having tools to feel inner peace when I need to, inner strength, improved self-esteem, physical health, getting support, people can count on me. And then another of the factors, spirituality of recovery. Look at these items. Being grateful. Whoa. I'm grateful for the back key. Giving back, that's helping. The combustion engine of recovery, helping. Helping, another one, helping. Appreciating that I am part of the universe, something bigger than myself. Becoming more open-minded about spirituality. Feeling connected to a spiritual being or force that helps me deal with difficulties in life. Recovery is spiritual in nature and has nothing to do with religion. And then here's the uncommon items. Physical and mental in nature and has nothing to do with spirituality or religion. Like it or not, a lot of people in recovery see it that way. No use of tobacco. I don't like that item. But Some do. It's religious in nature. It is to celebrate recovery people. Got to keep it. And non-problematic alcohol or drug use. 12-steppers can't stand that. It's moderated use, but there we have it. What were the most popular items? Three from the essentials. 90% of the 9,000 people said that these items definitely belonged in their definition. Honest, being honest with yourself, handling negative feelings without using, enjoying life without using. 3 elements in enriched definitely belong. Thomasina's item, process of growth and development, reacting in a more balanced way, the thing that's hardest for me, and taking responsibility for things I can change. Those are high percents for such a diverse group of people to agree to. So it made us feel like maybe we were on the right track. How to talk about this, how to think about it. The essentials, you've heard what those items are now. They're basic ways of being that are needed to sustain change away from substance use. Ability to deal with challenges, mental changes, and behavioral changes. Enriched is something more, looking outward and looking inward, and self-care. Spirituality. In recovery, helping is an expression of spirituality. What about the may belong in others? 10% or more of the respondents chose may belong in other people's definitions, but not mine. 1 was not prescribed drugs. 1, not living where you're overrun, somewhere that's overrun with drugs. And 3 in the spirituality factor. Not surprising that that would belong in some, but not mine. High rates of may belong in others for uncommon elements. All this seems to tell me is that, goodness gracious, you need to not use a Likert scale when you're studying things like this kind of concept in a heterogeneous group of people. Then we did a different kind of analysis called latent class analysis. And that's different than, don't look at the slide right now. That's different than factor analysis, because what this does is it, instead of looking at the questions and grouping them conceptually, it looked at the people who answered questions a certain way and grouped them. And then we looked at those groupings and we saw that there were 4,912 people who were what we could call 12-step traditionalists, because they thought most of the items definitely belonged. Then we had 12-step enthusiasts, another 2,000, who said they went along with some of the items definitely, some were somewhat. Then there was an important group of nearly 1,000 people who were secular. Recovery is physical and mental in nature were items that they liked. There was another 1,000 who were self-reliant. These people did not like the items that were social network related. And atypical, 382 people felt that a lot of the items didn't belong in their definition, but did with others. So if you were to be a treatment provider and were to give these items to your clients, you could maybe figure out, you got some secular people in there. Oh my goodness, we have some self-reliance there. Hitting on social network might not be the way in with them, or maybe it is, but maybe it's going to take some work. Now, there were 4 items that across all of these very different classes of people, you got to admit, these are different kinds of people, right? They all agreed with these 4 items. So what you can take to the bank is recovery is being honest with myself, handling negative feelings without using, enjoying life without using, and a process of growth and development. Recovery-oriented systems of care can use these definitions to inform the diverse range of pathways and give tolerance for varying beliefs about what constitutes recovery. Clinicians can use the elements to see where, I've already talked about this, I'm going to go ahead. I believe elements can reduce this, I can't see my slides anymore because of people on the right, so I'm having to look at my notes. Give me a second. They can reduce the stigma of addiction and recovery by showing the positive ways. Would you not agree that there's a lot of positives in those 37 items? They demonstrate the positive ways of being that recovery entails. And they provide researchers with a different measure other than abstinence and remission from DSM. Of course, almost none of them are using it because it's just not medical. And I only had 9,341 people, and they weren't a population-based sample where I randomly selected people, so it can't be right. But they can be used by you to guide service delivery beyond traditional treatment at recovery-oriented systems of care. And importantly, Elements can offer treatment programs and recovery programs, new topics to discuss in process group. Good programs are always looking at ways of freshening up and doing something a little bit different to make it more interesting, not just for the clients, but for the counselors. Now, a medical doctor in recovery himself, who was on the ASAM board, saw one of my talks or read my paper, I don't remember which, and he contacted me and said that he thought we'd gotten it right. And he wanted to use the elements in his treatment and aftercare programs in a humongously large HMO. And what he did, based on his view of recovery and from the framework of being a addiction doc, he grouped them in ways that made sense to him. And he had an authenticity group that he ran one day of the week, an emotional confidence group, a healthy relationships group, a right sizing of ego with spirituality group, and attention to neuroadaptation. And he's trying that out in his program. In the process group on authenticity, here are the items that he felt reflected what he wanted people to be talking about in his process group on authenticity. Are some of these old hacks things that you already talk about in groups? Sure, being honest with himself. But maybe this can provide some of you, and this is what I'm going to talk about in the breakout groups. Can you see using something like an authenticity group in your practice? What about emotional competence? Could you see using these items and asking people how they might see their lives if they could be doing these things? And well, this is what recovery looks like. This is what you can get. Healthy relationships, right sizing of ego. I'm just giving you time to read. Neuroadaptation. That's it. We disseminated the heck out of this and have many, many papers, all of which you're welcome to read. I want to thank my research partners, the 10,000 study participants, my research team, and the funding. And with that, I think I will get out of here and not share my screen. And I think we're going to do the breakout groups. How are we, Thomasina? Are there any points from the chat that you want to bring up before we do the breakout groups?
The only thing let's just overemphasize again is that this is completely coming from people in recovery. These items are coming from people in recovery, and with some very nice surprises, like the community. I'm so impressed with the community emphasis that I don't agree with that item, but I know other people in recovery do. So I go along with it. It's important.
Thank
That's
you.
it.
Okay, and it's 2:33 and we go for another half hour. So how about we break up into groups and talk about these items? And maybe I should put the items up on the screen. I don't know what I should do about that. Or maybe you'll just remember the items. You're smart. And think about how you might use these in your practice, if at all. Okay.
I suggest 6 breakout rooms. We have
Okay.
roughly 60 people.
Okay.
So that makes logical sense.
Okay.
So
And then we'll come back and talk about what the groups talked about. in the last
Okay.
10 or 15 minutes.
Yes, so as you zoom into your breakout room, please try to take note of which one you're in, because we'll go through room 1, 2 sequentially and
How
ask for
long will
comments.
the breakout be?
15 minutes.
15 minutes.
So I'll give you like a 5-minute warning. And okay, so all you do is click the invitation to join the breakout room.
What is happening?
We're going into breakout rooms to do small group discussion on the presentation. And so everyone has been assigned to a breakout room. If you just accept the invitation, you will be zoomed into it. The breakout rooms will last 15 minutes.
Uh-oh.
Okay, just a reminder to please mute yourself as you come back into the main space. Thank you very much. We're still missing better than half, so we'll give it a few more minutes for people to zoom back in and join us. Okay, so let's start with group number one. Do you have any feedback you want to give us? And everyone else, please, a reminder to please mute yourself as you come back into the main room. Group one, what did you discover in your conversation?
Is that our group? Because group one, I can't remember.
You're group one now.
Well, we discovered that I didn't have the authority to share my screen because I print screened some of the slides and we were trying to go over the elements of recovery, but I didn't find my cheat sheet until 30 seconds later to come back over to the big group. So sorry about that. But that's what we did discover. And learning more about the elements of recovery is something I'm really learning more about.
All learning about recovery, about Zoom, about so many things today.
A lot of things today, including learning how to operate the Zoom features. But
That's right.
actually,
And
even having a better definition of recovery is really important for me too. So I'm learning a lot from the group. I appreciate everybody today. Thank you.
That's wonderful. Anyone else from group one, or we could move on to group two?
I'll share real fast. I just
Cool.
noticed that, I like that the differences were so pointed out in terms of what different people believe recovery is. And the ones that were the most different from mine made me made me, I guess, compassionate and more able to realize like, wow, my version of recovery can be completely different than somebody else's. I appreciated that.
Thank you. Would someone from group 2 like to share their experience in the breakout room? Or someone who'd like to say they were in group 2?
I don't even remember what group I was in, but we had a cool group. We talked about how, the recovery gives a voice to people, and we get to hear people's definition of their version of recovery, which gives them acceptance, love, value, respect. We also talked a little bit about, the stigma aspect of it, right? And breaking down those barriers of that, because as we go through that recovery process, a lot of times people want to throw that stigma, those stigma terms and stuff in there, but having the courage to stand up to it and call it out, voice it, and, educate and move forward in it is helpful too. But, it depends on each person's personality and where they're comfortable with and, stuff like that. But very interesting group. I love my group. You guys are great. Thank you.
Great. Anyone else from Gwen's group want to speak up?
So I didn't get a chance to share too much in our group. I was in Gwen's group. It was a great group, but I experienced having many years working within a 12-step system, and 2 years ago switching off to an organization that has a broader definition, and sometimes struggling with that broader definition.
Thank you very much. Would someone from group 3 like to tell us about their experience? Or we
Dr.
can just
Michael.
go ahead. Go ahead.
He was the most informed and captured him and Nathaniel. Some of us, we were a little, I'll speak for myself. How about that? I was not focused on what the real question was. And so Dr. Michael came to the table with a lot more clarity. So go on, sir.
Hey, in our group, there was a young man there who was speaking about basically his experience, and felt that he was sheltered in terms of his addiction, what it may be, and his own is basically mental health, and he has a therapist and a psychiatrist. Okay, and from what I come away with that, many times there's a conflict between the psychiatrist, who is basing his interpretation on medication, and the therapist talking. And being a sheltered person, that person get caught in the middle, and sometimes they have to stay quiet than speaking out. And recovery, a person should have the free access to express themselves. So that's what I got out of our group.
Thank you. I think we can abandon the group numbers and just open it up to anyone who'd like to share. We've got like 7 minutes left in this session. Any other questions about the presentation?
Well, I guess one of the things that really came across to me was the way that this study questioned traditional sources of knowledge and who gets to sort of be in charge of setting agendas and who gets to decide what's important and what's not important. And, we live in a democracy, majority rules. And yet when you have that, like if Dr. Kaskutas had taken that approach with the majority rules in looking at this question, then a lot of interesting nuance and detail would have not been uncovered. I mean, I think that what we want is to leave no one behind in the world of recovery. Like if there are some people for whom a certain intervention doesn't work, then we need to take a look at why it's not working for them and figure out what their needs are and try to respond to that. And that I feel like the language that we're looking at here suggests some of that. Like, for example, the 1,000 people who identified as secular, agnostic, or atheist probably are going to have different needs than someone for whom they define recovery as either religious or very spiritual. Like that definitely has practice implications, I think, and suggests really different needs. Whereas if we were just looking at, okay, well, what do most people think, then that minority view would not have been revealed. So I think there was a lot of really interesting and valuable kind of details in the language that came out. I really appreciated, someone in our group, we were group number 6, Raquel said that she thought it was really interesting that abstinence is not a term that many people understand. I think there's a lot of terms that are considered to be recovery terms that people struggle with, like anonymity. A lot of people can't pronounce it. And yet it's one of the foundations of the 12-step movement, So I think looking carefully at language and what it means to people and how people express their ideas, how people communicate, was also something that this study was doing. I thought that was really interesting and useful. I could say more, but I'm going to stop there. So thank you.
Thank you, Libby. I would also add, just as someone with long-term recovery, that I found it interesting to see such a broad community identifying as being in recovery, and that it's really useful.
We're gonna
to-
probably
I'm
email
sorry,
you
I'm
on
gonna
that,
share
but yeah, we're
space.
gonna reach
It's
out to all
really
the
useful
speakers
as a person in recovery to not have my definition be the only definition that I consider to be in recovery, right? And in the peer community, I think that's even more important, because we may come into contact with people who really need the tools and support that are available through self-help support groups. But for any number of the identifying factors that were in the research, my path to recovery isn't their path to recovery. So I just thought that was very intelligent and eye-opening, and I appreciated the research. Thank you. Susan, you can unmute yourself. Go ahead.
I have a question. You just used a term that I've never heard here. Remember, I'm in Tennessee, and we're a little backward compared to you California folks. What is, describe your recovery?
You're asking me?
How did you say that to begin with?
Gosh, I don't remember, but I think it was along the lines of how I define my recovery and what my definition of what recovery is.
You're in undefined recovery is how you said it.
Oh, no, I don't think, I think what I meant to say is the way that people in the study self-defined, they defined themselves as being in recovery through pathways that, like, for example, people who aren't entirely abstinent from, drugs or alcohol or
I'm
whatever.
hearing you in the definition. It's the way I heard it in the beginning. Okay.
Okay.
I'll call you if I stay confused.
You can email me. We can talk about it forever.
Yeah, it's the way you identified yourself as a person in.
Oh, I said long-term recovery.
Okay, that was my hearing. Okay, I got it.
Okay. I mean,
Nathaniel, did I see your hand up?
Yeah, I just, I'm kind of piggybacking, I think. I just thought it just was interesting to me because, like, I've always, and I kind of mentioned this in the group, that, I see recovery as a personally defined thing, right? So it's interesting to have like these kind of consensus thoughts, like what it is, right? For example, like I'm not a person that struggles with substances, right? More like what I am is a person that deals with like mental health things, right? So I don't know that I necessarily consider substances. So it's interesting to like hear like how a lot of people considered recovery to be an abstinence from alcohol or substances, right? Yeah, that was kind of what was on my mind.
Let me ask you a question. Would you, aside from the abstinence factor, that was those 3 items that were at the very beginning of the 33 items, did the other items vibe with you? Did they make sense to you, that it's about being honest with yourself,
Totally. That,
dealing with negative things in a positive way,
right.
taking better health care of yourself?
Right. And even the pieces around not using a substance, like when you're going through a rough time, and not using a substance when you're going through a good time, right? Like, I don't use substances, but like it kind of broadened my I think it kind of broadened my thinking around it, really.
Okay, thank you. Thank you.
Well, that's 3 o'clock by my Greenwich Mean Time phone. So that is the official end time for this.
Do we have time for one more? I saw John Aguirre's.
I was just gonna say, like, you can hang out here and continue talking as up until the next session starts at 3:30.
Thank you.
So we have plenty of time. What I'm gonna do is I'm gonna stop the recording